Katie, and welcome back to the second and final vlog of this series, Crenshaw's Intersectionality and Healthcare Disparities. Last time I introduced you to Kimberly Crenshaw and her theory of intersectionality, but today we're going to put it into perspective through the lens of healthcare disparities from my position as a clinical staff member at Brigham and Women's Hospital in Boston. The first thing that I want to do to really put these healthcare disparities into perspective is just provide some facts on healthcare disparities that exist here so that we can then go on to explain how they come about. So these are just a few facts, and there are many more healthcare disparities that exist within our community, but this is a brief overview of some that I think are particularly important. So in 2010, Black people were 30% more likely than white people to die prematurely of heart disease, and more than 50% more likely to die prematurely of a stroke. So that is very significant. And then in 2016, a study found that LGBTQ people were more than twice as likely as either heterosexual men or heterosexual women to have a mental health disorder in their lifetime. A third fact is that in 2018, a gender-based study on chronic pain management found that as compared to men, women actually received less effective pain relief, they received less pain medication with opioid pain medications, and they were more likely to receive prescriptions for antidepressants or referrals to a mental health practitioner. And the final fact that I want to introduce is that a 2006 study found that in the aftermath of the September 11, 2001 attacks, pregnant women of Arab descent had an increase in poor birth outcomes due to discriminatory ideologies and increased surveillance due to the Patriot Act that was passed that created a lot of anti-Muslim and anti-Arab sentiment in the country at that time. Now that I've provided some context on the healthcare disparities in our country, I want to talk more about how these disparities actually come to be. There are many different factors that cause or influence health disparities, and one could argue that almost every single aspect of a person's life comes into play, but I'll just talk about a few of them today. So a big component of healthcare disparities is insurance access. So we need to think about how people get health insurance and who's able to and who is not. So some people might get health insurance offered through their employer, or some people might have to pay out of pocket to buy insurance, or even to not have insurance and to have to pay out of pocket for all healthcare expenses. And then there are those who now qualify for Medicare and Medicaid, which has helped to remedy a lot of the lack of health insurance in the United States. However, the qualifications of both Medicare and Medicaid are relatively slim, so there are still many Americans who do not qualify and are not able to afford health insurance another way. And then there are geographic and environmental factors that also influence health disparities. So in terms of geography, we need to think about who lives near hospitals or primary care providers and who lives too far away from any, let alone good quality facilities to receive care. And then there's also the aspect of the environment, so things like exposure to pollutants, toxins, carcinogens, and other chemicals. So a great example of this that many of us are aware of would be the Flint, Michigan water crisis, where the marginalized community of Flint, Michigan was affected by this poor water quality, which would not have happened in one of the more wealthy suburban communities where they could afford better water treatment. A third factor that contributes to healthcare disparities would be the socioeconomic status. So this includes different aspects of health such as food, insurance, as I discussed earlier, your housing that you're able to afford, and what type of neighborhood that might be in, whether it's a safe neighborhood or a neighborhood that's not so safe, your access to medications, your ability to have paid sick leave, and the list goes on. So socioeconomic status is really a major factor in one's healthcare outcomes. And then finally, I want to talk about education, which is often correlated with socioeconomic status, but because it is so relevant, I think it's important to discuss it separately as well. So education plays into a person's health literacy, their health behaviors, and their ability to get a good job where they have that high socioeconomic status so that they can afford good health care. So with this context of how healthcare disparities come about, I want to talk a little bit about my perspective from a hospital staff member about healthcare disparities in our community. So something that I have noticed a lot as a staff member is I've come to be very mindful about the patient populations that we see on our floor, because my floor is a GI surgery floor. So a lot of the procedures are elective, and because it's GI, a lot of times people aren't aware that they're having issues, or at least they're not able to clearly understand them and diagnose them. So a lot of times there are expensive tests like CTs or x-rays, or expensive labs that are required in order to diagnose, and then the procedures are elective. So we have to think about what it takes for a person to have access to this medical care and to get this surgery. And I've noticed that we see primarily white people on this floor, and beyond that we see primarily white men who are American born, who speak English, who are heterosexual and cisgender. So that's clearly significant, and it is not random that this is the patient population that we see primarily. That is systematic. There is a reason why these are the people who are able to have access to and to afford this care. So a story that I want to provide to really put this into context is a story that one of my nursing instructors told me from her time as a nurse. So there was this patient who was an elderly Islamic woman, and she was not able to communicate her wishes because she was very ill, and she also did not speak very good English. But her family would come visit her every day, and they had expressed to the care team that, as was Islamic tradition, they requested that she have only female caregivers. However, my nursing instructor was working one night, and she saw that this patient was assigned to a male nurse, and there was only one male nurse working that night, so there was truly no need for her to have not been assigned a female nurse. So she confronted the staff about it and asked why this patient's and her family's wishes were not being respected. And the response that she received from the other staff members was, quote, "We don't do that overnight when the family isn't around to notice." And so we have to ask ourselves, why wasn't this patient's and her family's wishes respected? Was it because she was a woman? Was it because she's elderly? Was it because she is sick and she can't communicate her own wishes? Is it because she is a person of color? Is it because she's from the United States and she doesn't speak English? Or is it because she's Muslim? We don't know, is ultimately the answer I can give. We do not know which of these factors contributed, so we have to assume that any and all of them contributed to the mistreatment of this patient. So here we can see how this patient's many identities all came together to collectively contribute to her mistreatment. We can assume that many prejudices were involved, such as sexism, racism, ageism, ableism, xenophobia, and Islamophobia, and perhaps even more that we were not aware of at that time. Because COVID-19 has been such a significant part of all of our lives in this past year, I want to finish off by talking about COVID-19 and looking at the ways that healthcare disparities have affected this pandemic. So I'm going to ask a series of questions here, and I want you to think about who comes to mind. What do they look like, and what are their identities? So last March and April, whose job allowed them to work remotely from home? Who had the technological capabilities to work from home or do school from home? Which children had meals and weren't left hungry because they were out of school? Who had access to COVID tests or medical care if they became ill with COVID? Who had an address that they could receive the stimulus check at? Who had a social security number to qualify for unemployment or a stimulus check? Who could afford childcare or a tutor for their children studying at home? Who had the ability to live in a socially distanced place? Who could watch the news or read online about COVID updates? who could buy masks or hand sanitizer or go to the store and stock up on toilet paper or extra food because they lived near a store and they had the sufficient funds to plan ahead and purchase ahead. Who had a safe home to stay at where they were accepted and comfortable during quarantine? Who came to mind here? And more importantly, who didn't come to mind? What did they look like? What did they not look like? COVID-19 has really brought out all the intersections of our many identities, and we see that the effects of the pandemic are not random. It is systematic and it is systemic. There are certain people with certain identities that are disproportionately affected compared to others, and that is not random. In the same way that I began this series, I feel that it is important to end in the same way, and that is with Kimberly Crenshaw. This is a quote that she said to Time magazine. I think it's particularly relevant to the point that I have made here about recognizing how disparities come to be and understanding the role that we play in healthcare disparities as well as in intersectionality as a whole. She says, self-interrogation is a good place to start. If you see inequality as a them problem or an unfortunate other problem, then that is the problem. Being able to attend not just to unfair exclusion, but also, frankly, to unlearned inclusion is part of the equality gambit. We've got to be open to looking at all of the ways our systems reproduce these inequalities, and that includes the privileges as well as the harms. I now encourage you to look within yourself and think about your own identities as well as your own prejudices that you may hold against other identities. So which of your identities might put you in a position of power, and which of your identities might put you in a marginalized position? For many of us, we probably hold a combination of both identities of power and identities of the marginalized position. So think about the ways that our identities contribute to our privilege or our lack thereof, and the way that our identities affect the way that we perceive ourselves and others in our communities. Thank you for joining me in this series. I hope you've learned a great deal about Kimberly Crenshaw, her theory of intersectionality, and the healthcare disparities that are so prevalent within our system. Thanks. Bye.